normal link. So anyway, I'm in. Good evening, everybody. Hi, Pankaj, and hi, Sunny, and everybody.
Thank you, sir.
Minister Rao, Sharad Desai, everybody.
Good evening, sir.
Thank you, sir. Who's the organizer today? Dr. Kiran Kothari or?
Dr.
Kiran Bhai.
But
Kiran Kothari, sir.
He said he might not be able to join. He has excused himself and asked you to excuse him. He might join sometime in between, but he's not there.
Yeah.
We are live now, sir.
Okay.
Good evening, everyone. Welcome to today's chapter of the IASO Masterclass series presented to you by the Academic Council of IASO. I request our President, Dr. Anna Gupta, sir, to please open the session.
Yeah, good evening, everybody. It gives me immense pleasure to welcome you all to today's 19th PG Masterclass. I think the Academic Council has been doing a wonderful job. So within no time, we have reached 19th session without any miss in between. Every fortnight, we had been organizing the PG Masterclass, and it has been highly successful with a lot of footfalls, and we are getting good comments, remarks from all the postgraduates who are attending this PG Masterclass. Today, I believe the topic is carcinoma tongue. We have very eminent faculties. Most of them are very good friends of ours. Dr. Pankaj Chaturvedi from TMH Mumbai, Dr. Asani Malhotra from Kolkata itself, and Dr. Sanjay Desai, our EC member, who's the local host. And his student, Elroy Sulhana, is the presenter today. And at the end, we'll have Dr. Pankaj Chaturvedi giving the expert talk as well. So I'm sure, like any other PG Masterclass, is going to be highly successful once again. A request to all the attendees, please become members of IASO. If you have not become a member yet, just need to log into iasoindia.in, and it's quite easy. You can become online member. So just need to get in touch with us. Thanks once again to the organizers, especially Dr. Kiran Kothari, who I understand could not join today, but he's the main organizer today, along with obviously the three other past presidents, Dr. Arun Chaturvedi, Dr. Rajaraman, Dr. Saringi. And the chief coordinator or the convener is Dr. T. Subramanish Rao, ably assisted by Dr. Sajan Shukla. So without wasting any more time, I request Sajan to take the meeting forward. Thank you.
Thank you, sir. I invite Dr. Sharad Desai, sir, to please introduce our examiners, give a brief introduction of them. Thank you, sir.
Good evening, everyone. Good evening, IASO members and the student surgical oncology. Today's masterclass is a case of a malignant lesion of the tongue, and the presenter from Indore, Madhya Pradesh, is Dr. Saldana. Elroy Saldana is a student of Dr. Sanjay Desai, who is the internal examiner. Dr. Sanjay Desai doesn't need any introduction. He's an eminent teacher and a very popular oncosurgeon of Indore. And he's an executive committee member of the Association of Surgical Oncology. He is a product of the Gujarat Cancer Research Institute, Ahmedabad, and he will be the internal examiner for today. The other examiner, Dr. Ashwin Malak from Kolkata, is a medical director and the chief surgical oncology, Central Hospital, South Eastern Railway, Kolkata, and he's an eminent surgeon of Kolkata. He's a past alumni of the Tata Memorial Hospital. The final examiner and the expert for today is Dr. Pankaj Chaturvedi. He is the professor of the head and neck department of Tata Memorial Hospital, and he really doesn't need any introduction. He is also the Secretary General of IFNOS, the International Federation of Head and Neck Oncology Societies, and he is also the officer in charge, the brain behind the Mahamana Pandit Madan Mohan Malviya Cancer Institute at Varanasi, which is coming up. And he has worked, I know he has worked tremendously for developing this hospital over there. He's the Deputy Director for Cancer Epidemiology, and the work he has done as anti-tobacco crusader is very well known to all of us. Indian Association of Surgical Oncology, I welcome all of you, and let us start the session, sir.
Thank you, sir. Some housekeeping instructions for the session. For our candidate, Dr. Elroy, we request you to give to-the-point answers, and there's no harm in mentioning if you don't know a particular one. It maintains the flow. And we also invite you to keep an open mind and not be too narrow to your diagnosis. For our dear examiners, this is an online webinar with a lot of live crowd here as well as on YouTube, and also future students will be viewing this on YouTube. So if the candidate incorrectly answers something, we please request you to give the expected answer. For the timekeeping, the first part of the session is the mock examination, which will be given 60 minutes. At halftime, I'll be reminding from my side, and as well at the end of the case discussion part. Now I invite Dr. Elroy to please start his case presentation. Over to you, examiners. Thank you.
Is my screen visible?
Yeah.
Yeah.
Good evening, examiners, respected teachers, and my dear colleagues. I'm Dr. Elroy Saldana from Sri Aurobindo Institute of Medical Science, Indore, and I'll be presenting a case of a 40-year-old male rickshaw driver who had presented with complaints of ulcer in the left border of tongue from past 7 months. He also complained of pain in the site of the lesion from past 5 months, and he complained of difficulty to communicate from past 1 month. An apparently normal patient had noticed an ulcer in the left lateral border of tongue, which was insidious in onset, gradually progressive. The lesion was associated with pain, which occasionally aggravated, and occasionally it radiated towards the left ear. He also gives a history of excessive salivation and inability to pronounce certain words, and this is from past 1 month. Patient didn't give any history of difficulty in swallowing or chewing. There is no history of change in voice, decrease in mouth opening, loosening of teeth, sharp tooth associated trauma, or neck swelling.
Elroy.
There is no.
So go back.
Yes, sir. Yes, sir.
Yeah. So let us freeze at this point, and you have taken the history. Now, based on the history, what would be your probable differential time? Let us not go ahead. With a person coming with a non-healing ulcer, pain occasionally radiating to the left ear, if we just have this information, what is your differential diagnosis?
Considering the duration and aggravation of the pain, I would like to give two differential diagnoses. One, it could be a malignancy, and second is the non-specific ulcer.
So what is that non-specific ulcer?
It could be aphthous ulcer or a traumatic ulcer.
Excellent. Now, when you say excessive salivation, what is the reason for excessive salivation?
Whenever there is an ulcer, it creates a little bit of irritation, and it causes a foreign body reaction, because of which there is a autonomous stimulation and leading by excessive salivation, sir.
That is one. The second is that usually because of the pain, the deglutition, which is automatic, which is spontaneous, gets hindered. And that is why every time they move the tongue, there is a pain. So there is a tendency to keep the saliva in the mouth.
Okay, sir.
Now, if this man had a history which was painless ulcer in the tongue, okay, what could be the reason? Painless ulcer. So what we have talked till now are the painful ulcers, correct?
Yes, sir.
Either they are aphthous. If there is a painless ulcer, that this patient did not have all this, but you had just found the ulcer, will the differential diagnosis change?
Yes, sir. It could be due to tuberculosis, or it could be because of syphilis.
So tuberculosis, syphilis, you know, it is there in the textbook, but yes. I don't know whether Sanjay, you have seen syphilis.
No, I have not seen.
Not seen. But what is more often seen? That is dental ulcer. That is dental a traumatic ulcer. Isn't it, Ashwin? What do you say?
Yeah, exactly. So
Because
one of those chronic traumatic ulcers.
yes, and it mimics cancer very closely. So all those who are listening, do not jump to a diagnosis of cancer as soon as you see ulcer in the tongue. There has to be, and what is more beautiful, that what is painless can be a dental ulcer, what is painful can be an aphthous ulcer, and carcinoma can be in between. Early carcinoma may not be painful, but as it advances, it becomes very painful. And Elroy, whenever,
Yes.
and all the students, whenever you have painful tongue and you suspect carcinoma, it is not an early cancer because it has gone deep into the substance, invaded the nerve, and that is how you get the referred pain into the ear. So many a times you will see patients coming holding their ear. You must have seen when they hold their ear, that means by facies, by the appearance, you can make out that it is a T4 or at least T3 tongue cancer. Perfect. Sanjay and Ashwin, can we go ahead? Go ahead, Elroy.
Yes, sir. There was no history of weight loss, and there was no history of cough with breathlessness or hemoptysis. Coming to the past history, patient didn't have any medical comorbidities, no history of radiation exposure. However, he gives a history of traumatic tooth avulsion of lower incisor at the age of 12 years. Proceeding towards a personal history, his diet was mixed. There was his appetite was normal. His bowel and bladder habits were regular. Sleep was sound. He chewed tobacco for 17 years and he quit 2 months back. He also consumed alcohol for a period of 9 years, which was around 120 ml per day, and quit 3 months back. In his family history, there was no history of any malignancy in the family.
So, Elroy, go back. So, there are three elements that need discussion. Yes. Because that is how we will build our case towards,
diagnosis,
causation and diagnosis. One thing that you have told, that there was a traumatic tooth avulsion. That means there was a sharp tooth. Then there is tobacco. There is alcohol. Correct? There are three elements. Now, can you tell me, how does tobacco cause cancer?
Now, this particular patient gave a history of placing a quid on the left lateral aspect of tongue. Usually tobacco, it causes a chronic irritation by which it forms a local inflammation, forms DNA adducts. It also inhibits glucuronidase transferase enzyme. Also, it inhibits P450 enzyme and causes P53 mutation. Because of this chronic cycle of irritation and inflammation, it leads to dysplasia, metaplasia, and thereby malignancy.
So there is, you're right, very good, excellent. So there is an element of, again, chronic irritation, inflammation, but there is a direct genetic damage also.
Yes.
And that direct genetic damage, as you rightly said, P53 deletion and PRB deletion, all that happen even in the absence of inflammation or irritation. Because when you say smoking, now smoking can also cause tongue cancer or mouth cancer. There may not be same as smokeless tobacco where chewing is common. So there can be a direct genetic damage. Now tell me, he quit 2 months back. There are a lot of patients who does say that I stopped smoking 2 months back or 2 years back, yet I got cancer. Okay. Does smoking, quitting 2 years back or 2 months back decrease the chance of cancer?
It doesn't decrease for a short period of time. It is over the years, the incidence of the malignancy decreases, probably minimum of 10 years.
Correct. So there is a decrease in the incidence, there is a decrease in the chance, but it never comes back to the 0% or same as the non-smokers. They always have a higher incidence. Now, Elroy, how does alcohol cause cancer?
Now, in this patient was chewing tobacco, and alcohol acts synergistic in the mechanism of action.
No. Alcohol alone. Forget about tobacco and alcohol.
Alcohol causes increases the solubility. It causes irritation. Also, alcohol causes DNA adduct formation, and alcohol also leads to formation of aldehydes, which leads to chronic inflammation. Also, alcohol increases the P450 cytochrome metabolism. So all these mechanisms collectively lead to formation of malignancy.
So most important is acetaldehyde formation.
Yes, sir.
Because acetaldehyde is a group 1 carcinogen. So where does the acetaldehyde form?
In the oral cavity, sir? I'm not sure.
In the liver. So the alcohol, when it is going to the liver, it detoxifies, and that time acetaldehydes are formed, and that leads to the cirrhosis and other function. But how does alcohol cause oral cancer? Correct? Because acetaldehyde is formed in the liver. So how can it cause cancer in the oral cavity? There has to be a mechanism. So what happens that the commensal flora, the bacterial flora in the oral cavity, they also have an enzyme called alcohol dehydrogenase. And this alcohol dehydrogenase converts alcohol into acetaldehyde in the oral cavity itself. And that is where oral hygiene comes into the play, because then you have the bacterial flora carrying all this. So the acetaldehyde pathway, tobacco exacerbation pathway, permeability pathway, local irritation, inflammation, all these mechanisms lead to oral cancer. Perfect. And you wrote about the history, no history of malignancy in the family. So whenever you take such a history, you must be knowing about the familial oral cancer. That means the syndromes or family history where oral cancer is common. So can you tell me some?
Usually it is more common with P53 mutation. So the patients who are having Lee Foramen syndrome, Fanconi's anemia, also patients who are having a history of ataxia, telangiectasia, this family history is very significant. Also, familial atypical melanoma syndromes, these are all contributed towards the formation of head and neck malignancies.
Very good. So there is a Werner syndrome, there are Bloom syndrome. So all these mechanisms where there is a defective DNA repair mechanism, they have the higher predisposition to tobacco-related carcinogenesis. And the reason is that we are all flooded with carcinogens every day, but our body detoxifies it or it neutralizes it. And even if there is a DNA damage, we have the P53, that guardian of the human genome, which is sitting at the cell cycle, and it does not allow those cells which are having defective genes. But once tobacco comes in, this P53 is deleted or mutated, and therefore we have the defective cells which are going into the cycle. And when they go into the cycle, it leads to cancer. So ataxia, telangiectasia, or Lee Foramen, all Fanconi's anemia, they all have defective DNA repair mechanism where these abnormal genetic cells, they keep continuing proliferating without going to the apoptotic pathway. Is that clear, Elroy?
Yes, sir. Yes, sir.
Yeah. Sanjay, Ashwin, you want to say something?
No, sir. You're taking a good exam.
No. No. Elroy is a smart fellow. He has a bright future. I'm sure it's because of Sanjay. Go ahead, Elroy.
At this point, I would like to summarize the history. 40-year-old male, known tobacco chewer, and the history of alcohol intake, complaint of ulcer in the left lateral border of tongue, with pain occasionally radiating towards the left ear, and with a history of dysarthria. I'll proceed with the general physical examination. Patient is moderately built and nourished. ECOG score was 0. He was conscious, oriented. His vitals were stable. His height was 162 centimeters and weight was 52 kgs, with BMI being 20.3 kg per meter square. There was no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema.
What is the relevance of clubbing here?
In a chronic smoker, there will be a hypoxia features, and that will manifest as a clubbing, sir.
Excellent. And cyanosis also is a feature which happens in sometimes the chronic smokers.
Yes, sir.
Perfect. Go ahead.
This is a clinical picture of my patient. Coming to local examination, on inspection, mouth opening 2 fingers. Patient had a poor oral hygiene with nicotine staining of teeth and halitosis. Patient had a right lower central incisor teeth missing. However, on examination, there was no sharp teeth noted. An ulcer was noted on the left lateral border of tongue in the anterior 2/3 and reaching up to the posterior 1/3 of tongue, approximately 4 into 2 centimeter. And this ulcer was situated 1 centimeter distal to a tip of the tongue. And it was extending up to the midline. And there was a slough on the floor of the ulcer. On asking the patient to protrude the tongue, the movement was a little bit restricted. However, the floor of mouth, the rest of the oral subsides, and neck appears to be normal.
So Elroy, mouth opening 2 fingers, did he have something that restricted his mouth opening?
He never complained of restriction of mouth opening. He said it's persistent in this way for almost period of 10 years or so.
So if it is 10 years of history of restriction in mouth opening, what is the cause of this trismus?
There could be a possibility of underlying submucosal fibrosis.
So was it there in him?
No, there was no evident fibrotic bands noted in the RMT region.
What else could have contributed to not 10 years, but trismus in such patients?
If patient has got acute pain, patient may have spasm of muscles
Very nice.
of pterygoids, and thereby there will be a restriction of mouth opening.
And what is the reason why trunk protrusion is not happening?
It could be because of the ulcer must be, the depth of invasion must be towards the extrinsic muscle, or it may be involving the floor of mouth. So that must be restricting his protrusion.
Excellent. So trunk protrusion inability is a sign of extrinsic muscle involvement. And once there is an extrinsic muscle involvement, we know that staging is upgraded, and then extent of surgery, the outcome is not good.
Yes.
Perfect. Go ahead.
On palpation, my inspected findings were confirmed. Tenderness was present. Mouth opening was 3.5 centimeters. And ulcer infiltrative growth of 4.5 into 3 centimeters was noted in the left lateral border of tongue in anterior 2/3, reaching up to posterior 1/3. It was situated 1 centimeter distal to a tip of the tongue with surrounding induration. Base of tongue and floor of mouth was free.
Just go back. So there has to be consistency. In the beginning, the mouth opening was 2 centimeter. Now suddenly it has become 3.5 centimeter. So that means you literally stretched his mouth on palpation. But I ignore that. What is important here is that base of tongue and floor of mouth, usually it's very painful. So how do you really say base of tongue is not involved on examination?
I would ask the patient to open the mouth, and I would gently place my finger on the dorsal aspect of the tongue and request him to gradually try to swallow my finger. And that's when I will gently feel for the base of tongue without causing any gag reflex to a patient.
So this is again what I wanted to tell all of you who are listening to this. In 2021, no patient should suffer pain. And sometimes I have seen our residents examining, even in Tata Hospital. I'm not saying that it happens in the OPD. Sometimes we are quite, crude in our examination, especially when somebody is having such a painful lesion. So we have to be very gentle. If required, we can do a fiber optic examination to look for base of tongue invasion. So basically what I'm saying, as all of you youngsters, be very gentle with the patient. because you cannot imagine the amount of pain that one would suffer when you are palpating the base of tongue in someone who has a restricted mouth opening, disease going up to the posterior third tongue, and then doing a bimanual palpation to confirm the involvement of the base of tongue. So I'm sure you must have taken all the precautions. Next.
Tonsillinguosulcus, the rest of the oral subsides are normal. There was no sharp teeth or loosening of the teeth felt. On examination of neck, there was a solitary 2 into 1.5 centimeter node felt in the level 2 on the left side. It was round, hard, mobile, and non-tender in nature. There were no other palpable nodes in the rest of the level of the ipsilateral side or on the contralateral side. At the end of the examination, I did ideal, which was normal.
Elroy and friends, one very important thing when you are examining the tongue is the floor of mouth extension. Because these patients, they may not have only lateral spread, they may have a horizontal spread down along the mandible into the floor of mouth. So in addition to examination of the neck for the node, you should always examine the floor of mouth, usually the central area or on the sides, for the direct extension of the tumor into the floor of mouth. And it can be the direct extension which may be confused with the nodal metastasis, or it may be confluent with the nodal metastasis. But that floor of mouth extension is very, very important because it really helps you plan your treatment accordingly. Disease localized intraorally, disease coming into the floor of mouth, the node becoming confluent with the floor of mouth. This is entire spectrum, and this all not only leads to higher staging, poorer outcome, and then perhaps need for reconstruction. So many times I have seen youngsters examine from outside, but not assessing the floor of mouth.
Yes, sir.
Excellent, go ahead.
Coming to the systemic examination, the systemic examination was normal, sir. So at the end of examination, I would like to summarize: a 40-year-old male, a known tobacco chewer and alcohol intake, complained of a lesion in the left lateral border of tongue with pain, occasionally radiating towards the left ear and dysarthria. On examination, he had ulcero-infiltrative growth of 4.5 into 3 centimeters in the left lateral border of tongue in anterior 2/3, reaching up to posterior 1/3, and solitary 2 into 1.5 centimeter node in the level 2 on the left side.
Perfect. Elroy, can you tell me the pathway through which the pain radiates to the ear from tongue?
If the lesion is present in anterior 2/3 of the tongue, the anterior 2/3, the sensory supply is by the lingual nerve, and also by the chorda tympani supplies the taste sensation. So whenever there is an ulcer, it invades and causes the pain in the lingual nerve, which is carried along with the presence of chorda tympani. It is relayed into otic ganglion. From otic ganglion, the auriculotemporal nerve fibers arise, which supplies to the external ear. So that's how the pain is referred. And if the lesion is if the lesion is present in the posterior, there's a glossopharyngeal nerve which gets carried away to the tympanic plexus, and that will refer the pain towards the middle ear.
Excellent. So this has an afferent pathway, then it has an efferent pathway, and you can get a short note on this. So all of you should be very well versed with this entire mechanism of referred pain in tongue or in buccal mucosa cancers. Excellent. So Elroy, you have done the examination, you have found this lesion. Now what will be your next step?
I would like to give my diagnosis. The diagnosis is malignant ulcer of the left lateral border of tongue, T3N1MX. Following this, I would like to work up the patient towards my diagnosis.
Okay, I can call it T4, but again, I will not argue with you on T3 versus T4. That is fine. but go ahead. So you have a malignant ulcer of the left border of tongue, and tell me what will be the next step.
I would like to get a case-specific investigation and routine examination. For case-specific investigation, I would like to get a contrast-enhanced MRI of neck from the base of skull up to the clavicle, and then assess the lesion, the extent.
So first, you will do a biopsy, because sometimes in our cancer center, patients come with biopsy, so we tend to omit it. But yes, biopsy would be important. First. Correct? Because that is something that you do in the OPD. You don't have to refer somewhere. So you'll do a biopsy, correct?
Yes.
Now tell me, you are working in a fancy hospital, you have a facility for frozen section. You will do biopsy and frozen section, or you will wait for the final histopathological examination?
I would get a final histopathological examination, sir.
Why not frozen section?
Frozen section, in cases of 21%, it is found to be false negative and is not appropriate. The report will not be a conclusive evidence.
That is one. The other is that it's a resource wastage. Why it is a resource wastage? Because you have to do CT scan, you have to do so many things. So it is not that you are going to operate him in the evening, correct?
Yes, sir.
So use any facility appropriately with judiciousness. And again, false negative, false positives are always there, and it is never the confirmatory diagnosis. Perfect. Go ahead.
How will you do the?
Yes, Ashwin, go ahead.
Yes. How will you do the biopsy?
I would like, after giving a local anesthesia over the lesion, I would like to do the punch biopsy over the edge of the ulcer.
Do you really require a local anesthesia for doing a biopsy from that area?
Local spray might be needed.
Yeah.
Lignocaine spray.
Yeah. Perfect. So, Elroy, Ashwin asked a very good question, and I'm sure there are others, youngsters listening to it. Please ensure that once you take a biopsy, there should be a bleeding from that area. That's a simple thumb rule. Many a times you try to take a biopsy in the OPD and you only remove the dead necrotic cells, and then of course pathologist can't do some magic on that. So when you take a biopsy and there is a bleeding, that means you have gone deep enough into the live cells, and therefore you will have a representative biopsy.
Sir, even thinking of the biopsy material on the bulb also represents that you have got a good biopsy.
Absolutely.
The slough will not go on.
Absolutely.
It has to be narrow and deep, as Pankaj was saying, not wide, shallow, or taking the
Correct. Please go ahead. So you said that you will take a biopsy and the site of biopsy is fine. And many a times, Elroy and youngsters in Uttar Pradesh, Bihar, I'm sure in West Bengal, even in Madhya Pradesh, I remember patients were very averse to taking a biopsy because they had a notion that if you take a biopsy, the tumor grows. And they have a feeling that once you take a biopsy, then it becomes worse. So, Elroy, how do you handle such situations? How do you counsel patients?
It is required to counsel the patient and comfort them that this is essential for the diagnosis of the particular ulcer and plan for the further management. Because based on the biopsy, the treatment changes. If it's a benign, it will be something else, and if it's malignant, then we'll be able to guide them and treat them the earliest.
Yeah, and what happens, Elroy? See, biopsy is like a trauma. And once you have a trauma, there will be a bit of inflammation, pain, and other things. But that is temporary. It is not that it actually aggravates cancer. And this information, I think, has really led to many dentists. I don't know how many dentists are listening to it. They don't even do the biopsy. They are very afraid of doing the biopsy with the fear that it will grow. Okay, now we have dealt with the biopsy. Biopsy is, say, for example, suspicious of squamous cell carcinoma, correlate clinically. Okay, Elroy, this is the kind of report that you have got. How are you going to deal with this biopsy report?
So with this particular biopsy report, this particular ulcer will be confirmed to be a malignant. Then I would like to assess the local extent, the size, and plan for the further
I'm
management.
saying that
Repeat the biopsy.
the biopsy report is correlate clinically suspicious of carcinoma.
Then I would like to repeat the biopsy, take a deeper bite.
So sometimes what happens, Elroy, pathologists have not seen the patient, they have not seen the ulcer. They are sitting on the fence. And sometimes the biopsy form that we sent them, it is like a puzzle form where you just have the name of the patient, age of the patient, you don't write clinical history, you try to imagine that the pathologist will do wonders without knowing the case history. So this is a basic thing that we should write the history properly, that there is a 4.5 centimeter ulcer on the lateral border and all that. This really helps the pathologist. This you will know only when you marry a pathologist like me. So that is one. Second, try to get it reviewed. Review means that you pick up the phone, speak to the pathologist, tell them that there is a gross ulcer. This can't be anything else. Okay. And sometimes a telephone call can prevent a repeat biopsy. In the absence of that, certainly you should repeat the biopsy. Okay. So biopsy done. Biopsy is a squamous cell carcinoma, moderately differentiated. Next step.
I would like to go ahead with the imaging, sir, to assess for operability and further plan management plan.
So what is the imaging that you would like to do?
I would like to do a contrast MRI of neck I would like the views from base of skull up to the clavicle.
So I am sitting in a place in Jharkhand and my MRI machine is not working. What is the alternative?
I can get a CT scan done, but that will be ineffective in assessing the extent and the depth of invasion in the tongue region.
So Elroy, again, this is something that we have to understand. When you do surgery, a lot of the surgical extent is based on palpation, correct? It is not like a navigation surgery where you are looking at the MRI, which is integrated with the surgical tool, and then you are going to do that. Yes, MRI is superior because for soft tissue delineation, perineural invasion, floor of mouth extension, it is superior, no doubt about it. But if you have a CT scan available and you have a good radiologist or a surgeon himself is able to read the CT scan, it is as good. I don't know what Sanjay and Ashwin would like to say.
Yeah, I think very rightly said. I think a good examination under anesthesia is very, very important. In fact, whenever we do such cases, even if a junior is starting the case, one generally does tend to put on a glove and do an examination under anesthesia, a proper detailed examination under anesthesia before you allow him to start, so that you get an idea exactly as to what is happening. So palpation is of vital importance.
Correct. So Elroy, if you tell me what is the role of imaging in locally advanced cancer? So if you get a short note on role of imaging in locally advanced tongue cancer, what are the things that you will cover in that?
I would like to assess the local extent of the lesion, whether the size of the lesion, whether it's crossing the midline, it is involving the extrinsic muscle, whether it is involving posterior extent of the lesion, whether it's involving the base of tongue, and whether it's extending laterally towards the mandible as well as on the anterior tonsillar pillar. I would like to assess the surrounding subsides of the oral cavity. Also, I would like to check for the perineal invasion and also the lymph node status, whether there is a contralateral nodes are present or absent.
So now, very nicely you have said that I want to know the local extent of the disease and perilunar invasion. What cannot be palpated can be seen on the imaging. That is how we add up to that information. Now talking about the neck node, correct? Now neck node, are you interested in knowing the ipsilateral nodal status?
I would like to know the contralateral node status.
Perfect. So ipsilateral, you are not interested. The reason is that anyway, you will do a comprehensive neck dissection. You are not going to compromise on that. The contralateral is the lesion crossing the midline.
Should I show the MRI?
No, just I'm asking clinically.
Clinically, the lesion is not extending. However, the induration does extend.
Correct. So when the induration is crossing the midline, again, the dictum is that when that lesion crosses the midline, you have to do the contralateral neck dissection as well. The reason is that you have the lesion going there, nodal metastasis or nodal drainage going there. So in both the cases, what is more important as an MRI for such lesion is the local extent of the lesion, which will guide your surgery and more importantly, your reconstruction. Because surgery, you will certainly plan according to the palpation, but you have to be forewarned about the need for reconstruction and extent of reconstruction depending on the soft tissue loss. Okay, go ahead now. So what did you do in this patient?
Yeah, I've got a contrast MRI of neck done. This is a T2 weighted image.
Just stop there. So can you describe this?
Yeah, this is a T2 weighted image of head and neck. Here we can see that there is a lesion. Is my cursor visible?
Yeah, I can see the cursor.
Yeah. It's the lesion is visible on the left lateral aspect of the tongue, and it is present in the anterior two-thirds of the tongue. As we proceed downwards,
yeah, please.
The lesion is just coming towards the midline. However, it's not crossing the midline. Also, little bit of floor of mouth can be seen, and it is not involved. And also, the mandible is also not involved. As we proceed downwards, I would like to see the nodal status of the neck. In this patient, he has got a node at level 2.
Yeah.
This is the node seen on the MRI scan.
Elroy, how do we improve the efficacy of MRI in detection of the nodal metastasis, predominantly occult metastasis?
Fat suppressed images as well as stir images will give a better better image on nodal status.
Excellent. So stir images will be really helpful, and more important that nowadays you have software for diffusion weighted.
Yes.
So if you are using the diffusion weighted software, it comes as an extra software. Then you are able to do better delineation of occult metastasis, which may be missed otherwise.
Yes, I would like to proceed for,
yeah.
Sir, would you like to see another sections?
No, that is fine. Go ahead. Surgeons rely more on their fingers and their eyes than these radiological plates. What do you say, Sanjay?
Yes.
These are the slides.
Absolutely.
This is on the coronal section to assess the depth of the lesion.
This is very important. You can see the disease going in deep into the floor of mouth.
Yes.
Yeah. Okay, go ahead.
Yeah. This was the biopsy report of the patient. Yeah. Following this, I would like to work up the patient for.
Elroy, can you tell me the Broders classification for differentiation?
Yeah. It is classified into well differentiated, moderate differentiated, poor differentiated, and undifferentiated. It is if the differentiation is more than 50%, it is called as well differentiated. 50 to 20%, it is called as moderate. Around 20, it is called as poorly differentiated. Less than that is called as undifferentiated.
And how does it impact the outcome? Why it is important?
It suggests the aggressiveness of the lesion. If it's poorly differentiated, undifferentiated, it is more, the lesion is more aggressive, and there is early invasion of perineural as well as a lymphovascular invasion.
Yeah. So there was a time when surgery was the only treatment, it had great relevance. But in the era of adjuvant treatment and good adjuvant treatment, increasingly it is getting blurred, whether you really need to know the differentiation. So if you look at all the studies and try to find whether differentiation alone is an important prognostic factor or not, is very difficult to come to a conclusion, because as soon as there's poor differentiation, you give radiotherapy. And once you give it, then you cannot know whether this leads to higher recurrence and survival impact or not. But certainly Brodler's classification is important and we must know that. Yeah. Next.
So based on the investigations, I would, the lesion looks to be operable. So I will plan for the surgery. So accordingly, I'll get the investigations done.
Can you tell me that some indications of inoperability?
If the lesion is involving if the lesion is going up to carotid space, and if it's involving prevertebral lesion, prevertebral fascia, then it's considered to be inoperable.
Perfect. Somebody has asked, your friend is asking about the staging. What is the stage?
It is involving, it is going deep. So I would like to give a class staging as T4A and 1 MX.
Very good. It's a very good question. Indication of CT chest. So Elroy, what is the indication of doing the CT scan? Because we have done MRI of the head and neck. That is your choice, correct? Now the question is that, is there a need for, I would rather extend the question, PET CT or CT scan alone for chest?
If the nodal status, if the lower level of nodes are involved, like for example, it level 3, level 4, and N2 or N3 node status, that's when the CT chest will be ideal to assess for the metastatic. For this case, since it is locally operable case, we can plan for a chest X-ray.
So what happens, Elroy, examiner may like this, may not like this. It depends upon the examiner. Now, examiner might say that T4 N1 is stage 4A, correct? Yes. Stage 4A, we will have, say, less than 1% risk of metastasis, especially in India, where most of the patients, they have cancers because of the smokeless tobacco. Our population is not smoker. In US, every patient who has a head and neck squamous cell carcinoma, be it larynx or oral cavity, they will always do CT chest. And the reason is that it is part of their protocol, because majority of them are smokers. There is a chance of synchronous cancer in the lung or a metachronous, or sometimes there can be metastasis. So because of that, CT chest is compulsory and part of the insurance protocol and package, and therefore all of them will do it. Now, since we are doing an MRI, if you examiner wants to know whether what you have done for the lung, you can say that X-ray chest, digital X-ray chest has been done. If there is any suspicion, I would repeat CT scan. However, if the examiner insists that CT scan chest should be done, you cannot fight with it. The reason is simple, that many of the guidelines may tell that.
Differ.
Correct? Yes, Ashwin, you want to say something?
Hello.
Yeah. Ashwin, you want to say about the need for the CT chest?
I think what you said is absolutely appropriate. Perfect.
Now, Elroy, the patient is, Bollywood celebrity, and he has read that PET CT is a very, very new thing, and he would like to get a PET CT. So tell me, is there a role of PET CT in such setting?
At this point of time, PET CT doesn't have much role, and it will not need any more information apart from the local regional extent of the disease.
Perfect. So the PET CT, the only advantage is that it can be a one-stop shop. That means PET CECT. If you do a PET CECT, the CECT component will look into the disease, chest metastasis, and if there is a bone, liver or something. But again, you said very rightly, for stage 4A, we do not have a great evidence to say that we should do a PET CT scan. Someone asked about, Elroy, about whether we should do MRI for T1, T2 tongue. What would you like to say, Elroy?
Yeah. Presently, classification wise, they have included depth of invasion. So getting an MRI would be ideal because we would be able to assess the depth of invasion, and also we'll be able to assess the neck nodal status better.
Now, if one of a surgeon from TMH is the examiner, he would say that even for T2, you will have to do a neck dissection. So knowing that there is a neck node metastasis or not knowing the neck node metastasis doesn't matter, because you will do neck dissection regardless in a T2 lesion, correct?
Yes, sir.
But doesn't matter. You are right that, see, I want to tell all the participants here, including Elroy, use an investigation which is going to impact the management. Do not use an investigation just for the sake of it. Many a times we do certain investigation without any logic. And at that point, what happens that the cost of treatment is pushed without any tangible benefit to the patient. So many people, what they do sonography of the neck in addition to the MRI or whatever, because they want to assess the neck node for sonography guided FNAC. Now, this is very contradictory. The reason is that MRI itself is good for neck node metastasis, even occult metastasis. And having additional sonography to assess the neck is something which doesn't merit any attention. Sanjay?
Sir, Ayushman Bharat will teach them to do low-cost surgeries and low-cost investigations only.
That is another issue. I can understand. Okay, next. So this diagnosis is done. We have an imaging. How are we planning the treatment, Elroy?
So the lesion looks to be operable. So I'll plan for the surgery.
Elroy,
So
have you spoken to the patient? See, you are giving, you are not taking surgical decision. You are talking about in an examination.
Yes, I was coming to that.
Examination, all of you, I'm telling to all participants, don't jump to surgery. You say that this is a stage 4. I would like to explain all the options to the patient and then come to surgery.
Yes, correct? I was coming to that, sir.
Perfect.
Because counseling plays an important role in this case. So first of all, I would like to see whether he is, I would counsel him for a de-addiction, whether he is de-addicted from tobacco as well as alcohol. Second thing, I will also counsel him regarding the options for the surgery. Now, since it is a T4 lesion, he would definitely require to undergo near total glossectomy. So definitely he'll have a speech impairment as well as swallowing difficulty post-surgery. So I would like to counsel him, get a consultation from the speech therapist as well as rehabilitation prior to the surgery, so that there would be a better understanding. And then I would like to prepare him for the surgery.
Perfect. So when you counsel a patient, Elroy, for the benefit of all the youngsters here who are watching this, please explain how do you counsel the patient for or near total glossectomy?
First, I would like to explain him the etiology for which he must have developed this particular lesion. And later I would counsel him for de-addiction. And then I would say, based on the MRI, the extent of lesion and how much it is affecting his native tongue. Based on that, I would like to explain to him that this particular lesion requires a wide local excision so that the chances of recurrence would be low. And based on that, at least minimum of 7.5 to 8 mm margin is required. So based on his particular lesion, he may end up getting going for near total glossectomy. Later, I would also explain to him that he would also require ipsilateral neck dissection, comprehensive neck dissection. Also, on the opposite neck, he would like to undergo selective neck dissection up to level 4. Meanwhile, I will also counsel him that based on the based on the extent of surgery and the bulkiness of the flap, he may require or may not require the tracheostomy because it will significantly influence his post-op outcome. Also, I would like to give
before we go on to next step, what is the indication of tracheostomy?
That there are two indications for tracheostomy. One is intubation causes, other one is during a time of extubation. If the patient,
shall I tell you something which I have learned all having been in head and neck for 20 years?
Sure, sir.
Do tracheostomy whenever in doubt.
Sure, sir.
You can go on to the n number of explanations, but on table, sometimes you have that gut feeling that it is better to do a tracheostomy. So whenever you have that feeling, and let me tell you, brain works like an artificial intelligence. It is a cumulative experience that you have all the time. It cannot be put into the words, but sometimes you have that feeling, do the tracheostomy. So in this patient, never get fixed. See, please understand, and many of the youngsters, when they join the hospital, their tendency is to avoid a tracheostomy, believing that tracheostomy is really a morbid thing. But trust me, for you to sleep peacefully after the day's surgery, and for patient, one of those patients who you will have to re-explore, re-intubate in the middle of the night, if you lose, then that experience you will have only when you have gone through that.
Yes, sir.
And therefore, the threshold should be such that whenever in doubt, you do it. Okay, go ahead. Sanjay, you want to say something?
No, sir, it's okay. It's okay. You explained very well tracheostomy. Multiple times I have asked them to do tracheostomy during induction only, before starting the surgery. Once you do tracheostomy and proceed for it.
So many of the youngsters think that we are old and getting senile and getting, lazy. But trust me, it comes only by experience.
Yes, sir.
Perfect.
And
so you were talking about counseling. So you said that you will be able to tell that there will be a lot of tongue will be removed. There is a possibility of tracheostomy. What else you will tell?
Also, I would also guide him regarding the reconstruction options. He can have a pedicle flap or he can have a free flap. Also, the post-op, including the post-op morbidity, I would like to explain to him.
So basically what I am trying to elicit from you and want to give a message, this patient, the best curative option is surgery followed by adjuvant treatment. Whenever I see someone saying that patient is not willing for surgery, I see a surgeon not willing for surgery. If you counsel your patients properly, you tell them about all the consequences and you tell them about the possible remedies that you have, patients do agree. And this is the only, so this is like, see, chemotherapy, radiotherapy has taken away most of the cancers from us. But these are the cancers. Oral cancer is still it is in the surgical domain. Convince the patient, do the proper surgery, involve microvascular surgeons, give them good outcome, and that is how you relatively cure this patient. I'm not saying that they have 100% survival, but this is how you cure this patient. Okay, next, so you have planned surgery, patient is willing, but the relatives are saying that they want to take an option and go to another surgeon, and that surgeon says that the surgery of total glossectomy is obsolete and there is a new possibility of induction chemotherapy followed by surgery. So how do you deal with this new information that patient is coming and giving you?
Regarding induction chemotherapy, there are two trials. One is Licitra et al. As well as Zong et al. Based on these trials, none of there was no overall survival as well as disease-free survival benefit. However, if there was, in those conditions, if there was a mandible involvement, there was a with less disease bulk in the paramandibular region, then there was a possibility that the mandible could have been saved. If not, there is no definitive overall as well as disease-free survival.
Perfect. So you are absolutely right that there is no proven benefit that giving induction chemotherapy improves the overall outcome. However, it may help, as per that study, with regards to organ preservation. And that is exactly what Lisa Licitra's study showed. We also did, you must have read the publication in the JCO from TMH and also the NSET data from TMH, that NSET, okay, Elroy, let me put it this way. So Elroy, if you get a short note on induction chemo, you may get a long question also, induction chemotherapy in head and neck squamous cell carcinoma. You talked about 2 trials where, Lisa Licitra and Jong. What else you would like to say? Because it's a long question, you have to fill at least 6 pages.
Yeah. When it comes about induction chemotherapy short note, I would like to classify based on lesions, whether it is resectable, borderline, or unresectable lesions.
Excellent.
Now, if it's a resectable lesion, then these are the 2 trials. One is Licitra et al. As well as Zong et al. In these 2 trials, they showed that there was no overall survival benefit as well as disease-free survival benefit. However, like you have mentioned, there is a possibility of organ preservation of almost 27% in, as mentioned in Licitra et al. And in Zong et al., they mentioned there was a little bit of benefit, OS benefit with N2 disease. Now, there are other studies for the borderline resectable. That was a study done at TMH, Patil et al., where they mentioned that 43% of the patient was at the end of induction chemo, they were eligible for the surgery.
So they were inoperable or borderline, correct?
Borderline.
They were not operable oral cancer.
Yes, sir.
So for operable oral cancer, still you do surgery. For inoperable, borderline resectable, you may consider neoadjuvant chemotherapy followed by surgery. And you are right, 43% become operable. But operable oral cancer, again, there are locally advanced. So we are currently doing another study to know whether in locally advanced operable oral cancer it is beneficial or not. But Elroy, what is more important, and all of you to understand, if you have done neoadjuvant chemotherapy or induction chemotherapy for locally advanced, say, cancer, what should be the extent of surgery and margins? You got my question? Say, for example, in this patient, today, if I do surgery, I do near total glossectomy, correct? If I give induction chemotherapy and the tumor shrinks, what will be my extent of surgery?
I would proceed for a total glossectomy at that condition.
Oh, initially you were doing near total. After induction, you will do total.
The same level of excision will be there.
So you will do the same level of excision because there is an evidence that there may be ghost foci of disease left where. But this area, whether we should do as per the shrunken margin or we should do as per the original extent, is an area of debate. We can have another lecture where for 1 hour we can discuss it. But as of now, your extent of surgery may not change. So why I was saying that this patient has to be counseled, because somebody has told him about the induction chemotherapy and he has come back to you. You will say that the extent of surgery that I'm doing now may remain same even after the induction chemotherapy. And therefore, there is no added benefit. The only thing which happens, the treatment duration will get prolonged. That means from point 0, another 3 months for induction chemotherapy, then surgery, and followed by radiotherapy. Okay. Now, in this patient, if you have done surgery, correct? You have done the reconstruction. Have you done that, or is that there, the pathology report, or is not there?
No, we have just operated a patient. The pathology report is not available. Final histopathology.
In this patient, how will you plan the adjuvant treatment?
So based on the histopath report, I will like to proceed. Now, if the patient has got a T3, T4 lesion with lymphovascular perineural invasion and positive nodes.
Sanjay, I will take a break for 2 minutes.
Yes, sir.
Then come back. So you continue with the adjuvant treatment. I'll just join.
Okay, sir. Chalo, Elroy, start.
Yes, sir. So now, based on the histopath report, if the lesion is, since this lesion is T4, if it comes as T4, LVI positive, PNI positive, with positive nodes, then I would plan for adjuvant RT. But if there is a, with the node, if there is a extranodal spread, then I would like to consider the patient for CT-RT.
Okay. Your radiologist always wants to give CT-RT. Which is superior? Only RT or CT-RT?
CT-RT is superior. It has got a better overall survival when compared to the plain RT itself.
Yeah, what will be they using as an adjuvant chemotherapy during the radiotherapy part?
They will be giving concurrent CT-RT. Now there are two protocols which can be followed when it comes to chemo. Platins, cisplatin, 100 mg per meter square can be given 3 weekly along with the RT, or it can be given 30 or 40 mg per meter square. It can be given weekly along with the RT. So based on one study by Noran et al. From TMH, they have quoted that 3 weekly was more superior than that of a weekly regimen.
Does hypoglycemia help during the adjuvant RT protocols?
No, the hypoxia and hypoglycemia is a deterrent factor.
Deterrent factor, or they are now studies to give 4 units of insulin and give radiotherapy. It just gives a better outcome.
Yes,
it has been taught.
Yes, sir.
So is it useful or not?
It is useful, sir. Mechanism, I'm not sure, sir.
Okay. And what type of radiotherapy will you advise to this patient?
Again, it depends on the margin of the margin as well as the extranodal spread. If its margin is fine and there is no extranodal spread, then probably 60 gray with 30 fractions would be sufficient. If there is any high risk factors, then probably it has to be upstaged to 66 or 70 gray with 33 or 35 fractions.
Perfect. So I think we have been told that we have to pack up the case discussion.
Yes.
And we have to move. So
for your final thought.
We can't defy the diktat. We have to continue with the program. Okay. So next I go to my presentation, Shrijan.
Yes, sir. We thank Dr. Elroy for his presentation, sir. Before we go to your presentation, can we have some comments from the examiners for Elroy? Any tips for the other students also?
So for Elroy, I have one comment that he is very well read. He is very articulate. And I must say that I thought that I was taking interview of a faculty rather than taking the viva of a student. And this is how I would like all the students to remain composed, be to the point. And if you know something, fine. If you don't know something, then don't bluff. The reason is that when you give a wrong answer, then you are exposing yourself for two things. That means you don't know the answer for the question that is being asked, and then you are telling something which you perhaps don't know. So you are exposing in your two fronts. So avoid making bluffs or guesses. And examiner, please understand, any given point, the examiner knows less than the student, because the student has read more carefully, more, with diligence, and examiners usually don't read before the exam. So you know more than examiner, certainly. And examiner is only looking for your proper attitude, your algorithm that you have in your mind, and how you can be a good doctor when you pass your exam. That is the only thing that we have in our mind, because knowledge certainly you gain while you are working with your mentors. And of course, when you are working with Sanjay, I'm confident that you are a good surgeon.
Thank you, sir. Thank you.
I would like to thank all my examiners for being very considerate towards me, and IASO for giving me an opportunity to present this case.
Dr. Malhotra, sir, your comments, sir.
So I think it was a good presentation, as Pankaj has already mentioned, and the answers were to the point. As Pankaj has said, most examinees do know more than the examiners, but I think the point in an exam is that during the exam, it should not appear as such. So that's the only tip that I would like to give, and I think you followed that rule. So I think it was yes, we had a nice time.
Thank you, sir. I request Dr. Sanjay Desai, sir, and Ashwin Malhotra, sir, to stay till the end for the Q&A session. We request now Dr. Pankaj Chaturvedi, sir, to please deliver his expert talk. You have our full attention, sir. Would you share your screen, sir, or should I do it?
Can you see the screen?
Yeah. It's loading up, sir. Yes, sir. We can see your screen, sir. It's not full screen yet.
I'll do that.
It's visible now, sir. Thank you.
Perfect. So thank you, Srijan and Arnab and Dr. Arun, Subbu. It is indeed honor that you invited me for this masterclass. And it is always a pleasure to talk to students. So thank you again. Epidemiology is known to everyone. And slowly we are seeing that tongue is more common than buccal mucosa in rest of the world. In India also, tongue is catching up, and soon the time may come looking at the epidemiological data that tongue has almost equaled, and in certain parts of India, we already have tongue more than buccal mucosa. If you look at the geographical variation of the tongue cancer, again, India more in Chennai, but in general, if you see male and female incidence of tongue cancer as well as mouth cancer, that is non-tongue ICD classification 0 to 06, 03 to 06, is very common in India. And why it is common, I need not really dwell on this. All of us know that it is because of the smokeless tobacco consumption, poor oral hygiene, alcohol consumption, and in India, which is very specific, is areca nut consumption, which leads to oral carcinogenesis. This was a very nice study, which is by the Maura Gellison group and Anil Chaturvedi group, and they have shown that how overall there is a reduction in the head and neck cancer. But if you look at the HPV related cancer, especially the cancers of tongue, is rising in the younger cohort of the people. But overall, there is a decrease in cancer. Now, we did our own analysis of time trends of tongue cancer in India. And though on the clinical side, it may appear that tongue is becoming more common, but when you look at the epidemiological data and age standardized rates, buccal mucosa continues to be the leader, but this data was till 2012 when we are analyzing the current data. Now, this is the gender distribution, and this is a perception that, most of the time, it is that young women, no history, coming with tongue cancer on the lateral border is we are seeing more often now. And this, I don't remember 15, 20 years back when I started career in head and neck was common. Now, looking at the pathogenesis of tongue cancer, if you look at the entire pathogenesis, then starting from the normal epithelium to invasive squamous cell carcinoma, there are certain steps involved. And these steps happen at the microscopic level. That means we are having the normal cell to carcinoma, moderate dysplasia to severe dysplasia to invasive carcinoma. For all these cytological changes or microscopic changes, which are again pushed by the smoking, alcohol, areca nut and all that, there are sub-microscopic level or ultra-microscopic changes like P53 deletion, or we are having the PRB. Before that, there is a polymorphism of DNA repair genes. As we progress towards the cancer, invasive cancer, you can see that P16 down regulation is there, cyclin D up regulation, telomerase up regulation is there, VEGF up regulation there. So this is the whole pathway, and it is almost similar to oral carcinoma. So this is not something which is different. Now, we know that tongue carcinoma may have a particular predisposition for lymph node spread. Now, this is one area that has always been discussed, and this is always a perception that the chances of skip metastasis is very, very high in tongue carcinoma. Now, look at many studies that have looked at basically what happens. Skip metastasis means that the tongue cancer has metastasized to the level 4 without involvement of level 1, 2, 3. Then only it is skip metastasis. And there are old studies, Byers et al., where people have always quoted 15.8, and therefore we should routinely do the level 4 dissection in tongue cancer. Actually, if you read the paper carefully, that skip metastasis was not in absence of level 1, 2, 3 all put together. The reason was that absence of level 3 as a skip was used for level 4 metastasis to call it a level 4 metastasis. But actually, those patients had level 1, level 2 involvement. So more recent studies in TMH and elsewhere, it has shown that level skip metastasis is literally unknown if there is no presence of level 1, 2, 3. Usually, level 4 metastasis associated with presence in either level 1 or level 2 or maybe level 3. Now look at the 5-year survival, which is what we are showing here. In stage 1, it is almost 73%. In stage 2, the range goes up to 60%. Stage 3, 47%. And stage 4, it goes down. And this survival data is more of hospital-based data. And it may vary a bit between the centers depending on the type of treatment and extent of treatment. And these are some of the best case scenarios, because many of the times if you go to the population level, then many patients remain untreated or partially treated, incompletely treated, and therefore the survival data in our population-based cancer registry is much lower, maybe 1/3 of what is happening in the hospital data, because this data is restricted to those patients who come to Tata Hospital or any hospital and get treated. Now, T stage, I need not spend much time because we have less time. TNM classification, you already know, and I need not talk about it. The only thing is that now depth of invasion has also become part of it, and all of you should get well versed with the nodal metastasis. Now, these are the differences in the clinico-pathological factors between tongue and buccal mucosa. So by and large, we have seen that the chances of having adverse pathological features stage by stage and the same T stage or general overall stage, they have got more adverse prognostic feature. And therefore, maybe the time has come when the tongue carcinoma and buccal carcinoma, in terms of treatment strategy, in terms of maybe the prognostic outcome may be differentiated and rather than clubbed as a common pool of oral cancer. This has already been discussed about the physical exam. All of you should understand that to be a good surgeon means that you have to be a good examiner. And once you are a good examiner means that you have to more and more rely on your eyes and your touch and your examination, and there are no substitute for that. For good surgeon, before you operate, do the good visual examination and palpation before you put your incision either in the mucosa or in the skin. Many a times you take an incision in the oral cavity without palpation, without digitally examining, and then you realize that your flap is very close as a soft tissue margin, and sometimes you may have to revise the skin because of that. So whenever you are planning the incision of the neck node dissection, it has to be done in conjunction with the excision of the primary. That is more true for the oral cancer, buccal mucosa cancer, than for the tongue cancer. Now, this is the imaging protocol that why contrast enhanced CT is important. And Elroy has very nicely talked about the reasons why MRI is preferred over CT scan. And these are the images, again, we have already discussed. And you can see that in this patient, how the lesion is crossing the midline. And if it is not clinically palpable, this will tell you how to plan the reconstruction because of the extent of surgery that requires near total glossectomy, and also plan contralateral neck dissection. Now, these are the parameters which are imaging findings which have an impact on the management. So now radiology is not only something that guides surgery and guides surgeon, but it also helps us give a prognostic value based on certain features, and this publication delineates that. This again is an extension of that how depending on the extent of the lesion, you can understand whether this patient is suitable for surgery or not, and also plan your reconstruction that we have already discussed. Now, more important, I think, is to understand, do we need to know the neck node status by doing the imaging, and how does it help in detection of occult metastasis? Now, this was a meta-analysis. Lot of people get confused because what happens that there are two kinds of metastasis. One was DeBont meta-analysis, and the DeBont meta-analysis said that you should do a sonography guided FNAC, or you should do a USG which is superior to MRI CT. But when you look at the that study, the DeBont meta-analysis, that was for all neck, clinically N0 neck as well as clinically N plus neck. But if you look at the clinically N0 neck group, look at the sensitivity and specificity. Ultrasound has got a sensitivity of 78, specificity of 78%, and 66% ultrasound. CT has got 52%. Because we do not have very good investigation in telling us about the occult metastasis, the best way to know the neck node status remains surgery. That is the supraomohyoid neck dissection, which can tell us whether there is an occult metastasis or not. Now, talking about the margins, standard we have discussed, we should achieve at least 5 millimeter margin in histopathology. Now, we know that there is a shrinkage. We know that there is even if you do formalin fixation, there is sometimes a shrinkage of the margin apart from the natural elasticity of the tumor. Therefore, to get a 5 millimeter margin, you should put your knife at least on 1 centimeter in the patient, in the around the tumor, so that after all that shrinkage, you get at least 5 millimeter of tumor margin on all sides, including the soft tissue. Now, the students sometimes ask about the molecular margin, not proven. We can do a lot of discussion on that. But again, our reason to revise the margin or reason to take cognizance of the molecular margin is based on the evidence. We do not have a strong evidence whether we should do P53 or HER2 at the margins to increase or maybe make more precise the definition of the margins in surgically treated patients. Now, this is the algorithm. Quickly, we have less time, so I'll quickly go through this. T1, T2, T3, and all stage 4A. So up to here, if you see T1, T2 to T4A, all patients are suitable for surgery. When we come to T4B onwards comes the role whether we should do surgery or we should do neoadjuvant or concurrent chemoradiotherapy or whatever. Quickly go through this. Somebody had asked in the chat box, sentinel lymph node. Now, T1, T2 sentinel lymph node biopsy is certainly in some patients, in some countries, it is routinely offered. But please understand, when you do a sentinel lymph node, you have a patient who has come to you with T1, T2 lesion, occult, there is no clinically palpable neck node, and you want to plan the sentinel node. Therefore, this patient would require an MRI or a sonography to assess the lymph node status. Once there is a lymph node status, there can be two outcomes. Either it is positive, negative, or indeterminate. Now, if it is negative, no problem. If it is indeterminate or suspicious or positive, you will have to do a sonography guided FNSE and prove it. Now, the problem is after doing this basic radiological investigation, if they are truly negative on sonography imaging, then they are suitable for sentinel lymph node biopsy, and that requires a peritumoral injection of the radioisotope. And once you do the peritumoral, next day you can take the patient for surgery. You require a gamma probe. After the gamma probe, you identify the lymph nodes, send the lymph nodes for step serial sectioning. When the lymph nodes come positive, you recall the patient, do the completion neck dissection. If there is no metastasis, then the patient continues. If it is only isolated tumor cells and perhaps micrometastasis, you may not do a completion neck dissection. But if it is macro, or some people do even micro, there is a need for completion neck dissection. Imagine the number of steps involved in management or use of sentinel node in the management of neck node metastasis. And therefore, considering that it is very cost intensive, it is very time intensive, and it may cause discomfort to the patient, especially when supraomohyoid neck dissection, if it is done well, you just remove level 1 to level 4 or level 3 in occult metastasis, the morbidity is low, and it is a one-time procedure. When you are doing the primary tumor at the same time, doing 15 minutes extra work and removing the supraomohyoid levels of the fibrofatty tissue, actually it is curative. So it all depends upon the preferences, and we think that presently, if you are able to do a supraomohyoid well, then you may save the cost and time which is involved in the sentinel node biopsy and subsequent steps. But whatever you do, neck node management is important. And based on the neck node based on the neck node status, whether there is extranodal spread, whether there are positive margins, there are certain adjuvant treatment changes that happen. So presently, if there is an extranodal spread or extra perinodal invasion, what some PNI people call it, not perineural invasion, but some people call perinodal invasion, or if there is a soft tissue margin positive or close, then we give adjuvant concurrent chemoradiotherapy. That means we give cisplatin along with radiotherapy in such patient. But negative margins, depending on other features, we can consider radiotherapy alone. This is the whole algorithm for management of locally advanced, where starting from surgery to adjuvant treatment. And in adjuvant treatment, again, cisplatin is the most commonly used drug, usually 100 milligram per meter square 3 weekly, or 40 milligram, 30 to 40 milligram 3 weekly. Weekly is the option along with radiotherapy, and radiotherapy usually is 60 gray over 30 fractions. Now, nodal metastasis in tongue cancer, you can see that in early oral cancer, it is 24, and as you go advanced, it becomes 50%. And therefore, most of the patient, unless proved otherwise, they are benefited by neck dissection. And I'll show you our randomized control, which RCT, where it shows that 85% of the patient in this study were tongue cancer. Randomized control trial, patients were randomized into observation versus elective neck dissection. When we did elective neck dissection, overall survival improved by 12.5% and disease-free survival by 23%. And therefore, unless proved otherwise, most of these patients do require a neck dissection. Now, the question that people may ask, when to do imaging of the neck? We have to do imaging of the neck only when the tumor is less than, it's a T1 lesion less than 3 millimeter, or when you want, for any reason, want to observe the neck, that is the time when you do the imaging of the neck. If you have planned neck dissection, that happens because of this study, there's no point in doing a imaging to know the neck node status. Now, this is again a study which is comparing buccal mucosa versus tongue, which shows that tongue is likely to be more aggressive. It has more adverse prognostic features, and therefore the adjuvant treatment can be more enhanced in such patients. Now, this is another issue, neoadjuvant chemotherapy. It is being more and more used in controlled atmosphere, in controlled setting where we want to perhaps do a study. But outside the study, for locally advanced disease, where surgeon is not comfortable that he can remove the entire disease with free margin, then perhaps those borderline resectable cases, induction chemotherapy can be given. The other indication certainly is for organ preservation, and there are studies going on. We have done in Tata Hospital where rather than doing total glossectomy, we are finding more and more results where less than total glossectomy can be done. However, the role in inoperable tongue cancer is not proven as an induction chemotherapy, because if you look at the TAX 324 study or TAX 325, there the primary endpoint is not for advanced tongue cancer or inoperable tongue cancer to become operable. It was more for palliative, triplet versus doublet, and then the byproduct was whether induction chemotherapy can be given or not. So at this point, whether we should give neoadjuvant chemotherapy to inoperable tongue cancer to make them operable, that question has not been answered. But many a times we do see such patients whom we have given chemotherapy by labeling them as inoperable. Some of them do become operable. But again, I will not confuse anyone by saying that we should start practicing this. Now, this is again our own data, and Jong that there is a trend towards better DFS OS for borderline resectable tongue cancer receiving NSCT. Now, these are the types of defect that you can see, and depending on the type 1 defect, type 2 defect. So basically, the thumb rule is that if you are removing less than 1/3 of the tongue, you can consider primary closure. When you are between 1/3 to half, you are in dilemma. But anything which removes half of the tongue requires a reconstruction, and more than half, certainly it requires a reconstruction. So this is an algorithm. You can see the type 1 primary closure, type 2 you can do either a FRAF or ALT. Why we are doing FRAF sometimes? Because even the surgeons can do themselves. And only problem with the FRAF is donor site morbidity, which is quite disabling. But in India, most of our patients are lean and thin, and that is why it is very easy to do an ALT, which is not very bulky. Abroad, they have a lot of these patients with bulky obesity, and therefore ALT is not preferred. But in India, ALT sometimes is as good as our free radial forearm flap in terms of subcutaneous fat. But many a times we have done pectoralis major myocutaneous flap if the patient is lean and thin, and we can use it for reconstruction. Now, these are the early tongue cancers, and you can see how beautifully with the free radial forearm flap, it gives the shape. So articulation as well as swallowing is very easy in them. This is another advanced lesion for which reconstruction can be done with anterolateral thigh flap. But what is more important in these patients is rehabilitation. Surgeons cannot work in isolation. Please involve our physiotherapist and occupational therapist and give them exercises. Now, these are the differential diagnosis for youngsters, that there can be non-squamous cell carcinomas which may mimic or confuse. So this is just for the sake of enumeration that all of you should know, and examiner sometimes may ask you, and these are the short cases that you may get in time. And in the last, I would say that oral cancer surgery cannot be done in isolation, and therefore the mere outcome of the patient improves when there is a multidisciplinary team. So I would encourage that all of you who are going to pass out of the exam, try to work in a multidisciplinary team, and that is how you give good care to your patients. Thank you so much.
Thank you so much, sir.
I'll stop sharing just a minute.
Yes.
I'll do that.
Thank you, sir. That was a lovely talk. We now come to our last segment, which is the Q&A. We've chosen a few of these questions from the Q&A and the chat. What I've done is I've addressed these to one examiner each. However, all the other examiners are also welcome to volunteer their response. We'll start with the first question for Pankaj sir. Sir, how to approach a single adverse factor in histopathological examination like a PNI when it's T1 to T2N0 early tumor?
Very good question. So basically, whenever we are planning adjuvant treatment, usually we have to look at there are definite indication and then there are relative indications. Now, definite indication we are not doubting. So having isolated PNI in the absence of any other adverse prognostic feature is a contentious area for adjuvant treatment, because PNI can vary from intratumoral perineural invasion to extratumoral along the lingual, along the hypoglossal, along the trigeminal. So there are two different. Now this extratumoral PNI will be seen by imaging. If that is there, certainly you will plan your treatment differently and try to incorporate it into the tumor, even if it is beyond the gross tumor. So that is a separate aspect, and there adjuvant treatment is indicated. But sometimes when you do a primary tumor with all negative margins and you have a histopathology report where it shows that there is a microscopic PNI, now this alone cannot be a criteria for adjuvant treatment at this point unless there is a lymph node metastasis. Having said that, we have published our own data, a retrospective data, where we have seen that PNI alone, they have higher chances of recurrence compared to those who have no PNI. Now, whether it translates and warrants adjuvant treatment is the question that is being asked, for which I do not have a clear answer. But certainly, such patients have poorer prognosis.
Right, sir. Sanjay sir and Ashwini sir. Yeah.
No, it's okay. The answer is given by Dr. Pankaj.
Yes, sir. Our next question is to Dr. Sanjay sir. Sir, how early is re-irradiation safe in a case where there's an unresectable local recurrence?
Basically, when for re-radiation, safety margin is we have to discuss with the pathologist, and whether they have given radical RT or they have given a dose limited RT. When it is given a radical RT, re-radiation is very difficult because spinal cord involvement is there in all oral malignancies. They cannot re-radiate beyond 4,000 rads or something like that. But when we think of re-radiation after 2 or 3 years, then a definitive radiotherapy can be planned, but not before the 3 to 4 months plan. The re-radiation is not safe in any unresectable local recurrences, early recurrences.
Right, sir. Pankaj sir or Ashwini sir, any comments, sir?
So basically, we sit in the multidisciplinary clinic, and whenever we refer our patients for re-irradiation, our radiation oncologist, when they are in the forum, when they give lecture, they always show that there is an indication of radiotherapy. These are the indication, these are the contraindication, this is what is this guideline, that guideline. But when you send the patients to them, they all refuse. So this is only on paper that re-irradiation works, but in clinical ground, I have yet to see a patient to whom they have done re-irradiation. They all look for reasons not to give it. I'm sorry if there are radiation oncologists watching this.
Right, sir. We'll go to the next question to Ashwini, sir. So what is the rationale and is there any role of compartmental resections in tongue cancer?
So yes, this compartmental resections have been there for some time, and even in early lesions, sometimes there have this, because of the spread around the nerves, around the vascular structures, around the lymphatics, around the muscle, along the muscles. So there is this tendency, or there has been this a tendency of doing compartmental resections by some people. However, I think apart from certain instances, for example, in the infratemporal region where it's below the sigmoid notch, when you do a compartmental resection involving the infratemporal fossa, I don't think the evidence is strong enough to make it standard of care. So compartmental resections, yes, some papers have supported it, but overall, I think I would still consider it experimental, and in general, we do not do it.
Other examiners also agree with this, that yet to be the standard of care. Yes. Yeah. Next question to Dr. Pankaj sir. Is there any role for giving a radical CTRT followed by choosing patients for salvage surgery in operable oral cancers?
Role of CTRT, FB, Facebook, what is this FB?
Followed by salvage surgery.
FB, followed by CTRT followed by salvage surgery. See, please understand that whatever we do, it has to be based on an evidence. In India, we have a nice randomized controlled trial, and I think the only one coming from All India Institute of Medical Sciences. Another study came from the Singapore, and then we have enough of the SEER data that if you have operable oral cancer, please do surgery followed by either radiotherapy with or without chemotherapy, depending on the discussion that we already had. That is the standard treatment.
Right, sir. Our next question to Dr. Sanjay sir. How do we proceed when a patient refuses to cease tobacco and has a new cancer?
Sir, for this part of the patient, I would totally refuse the patient to treat. Basically, if he is not going to cease the causative mechanism, why should I bang my head on treating such type of patients?
Yes, sir.
I would totally refuse to treat that patient.
Yes, sir. This is not a scientific question, I would say. So let's take the opinion of other examiners also.
The beauty of smokeless, the beauty of oral surgery is that they can't chew gutka. Now the problem happens with the smokers. The problem happens with the smokers that once they get well, and they, I have seen that they get well after several years, they go back to alcohol and smoking once again, because these two, that does not require chewing.
Yes.
So what Sanjay is very right, that this is the time to counsel them that please understand that you have, because see, people take example that there are so many people who are using tobacco, but they have not got cancer. But this man has got cancer. That means he's susceptible and he's likely to have recurrence. He's likely to have comorbidities, and post-operative care and ICU requirement is very high. And therefore, this is the best chance to counsel him.
Right, sir. Last question for today to Ashwini sir. Is there any role of testing DNA testing for HPV in oral tongue today?
So as far as the oral tongue is concerned, well, there is no role of HPV DNA testing apart from maybe if you're carrying out some kind of research, it's a different thing. But generally speaking, there is no role as far as the management is concerned about testing for HPV DNA in the oral tongue. For the oropharynx space of tongue, yes, that's a different ball game. But as far as the oral tongue is concerned, I do not think that there is any role for HPV DNA testing.
Thank you, sir. I would like to thank all the three examiners from my side for patiently answering these questions. I now request Dr. Kiran Kothari, sir, to please give his closing remarks.
Yeah. Yeah, it was an excellent program as usual. IASO, I think it is 14th masterclass or 15th. I don't remember the number.
It's
But
19,
anyway,
sir.
17th, sorry.
19, sir.
19, sorry, 19. So it's really excellent efforts by we all, IASO. For this program, tongue cancer, I must thank first of all Pankaj Chaturvedi. With a very short notice, he agreed, and with my one phone call and the WhatsApp message, he said, yes, I'm in. Similarly, Sanjay Desai, whom I contacted first because it was their turn, their center and their student, his student, and Ashwini Malhotra from Eastern Railway Hospital from Kolkata. So all examiners, of course, they did very well. It was very nice. And I had really tied up in my family event, so I came very late. Anyway, the student, Elroy Sadhana, I think he did extremely well. That's what feedback I got because I was late. When I came, I think Pankaj was giving his expert talk. But anyway, we are really thankful to everybody. And the next master class is on penile cancer on 29th of July at 7 p.m. And over to Srijan or maybe Sharad Desai and Arnab Gupta.
A quick closing remark from my side before you all sign off. I'm sure Srajan and Sharad will have some more things to say, but I was really impressed, how the PG Masterclass was conducted today, like any other masterclass, and the faculties were excellent. I really enjoyed the talk of Pankaj Chaturvedi because I'm not a head and neck surgeon, but I got so much learned at the end of the session. The other faculties were brilliant, and the present, I must say, like Pankaj said, was as good as a faculty himself. So really enjoyed, and thanks to Dr. Kiran Kothari and the rest of the organizers for taking this academic session forward. Today's 19th session, just to let Dr. Kiran Kothari know, and you've all done wonderful job just to make this possible. Thank you.
So from my side, I must thank you, Pankaj, for seeing you after a long time. You are an inspiration for many of us. You are an eminent head and neck surgeon. Apart from that, you are a great family man. You are a anti-tobacco crusader and a great friend for us. We hope to see you in the IASO more and more often in the coming days, weeks, and months. So thank you all the participants for encouraging and making each of our masterclass successful.
Sharad, can I tell the IASO that surgeon was very sick in the morning and in the afternoon? I thought I'll replace him, but he came back and conducted this. So 3 cheers to surgeon.
Yes.
And IASO.
Great. Thank you, sir.
Thank you.
Thank you very much.
Thank you. Look forward to the next session. Thank you. Bye.
Thank you, everyone. We'll close our today's meeting. Thank you, everyone, for attending. Thank you, examiners.